Welcome to this lesson of your antepartum unit. In this lesson, we will cover the concepts associated with hypertension in pregnancy. The objectives of this lesson include: distinguish the difference between hypertension, preeclampsia, and chronic hypertension, describe the etiologic theories and pathophysiology of preeclampsia, associate the management of care of women with mild gestational hypertension or preeclampsia versus severe gestational hypertension or preeclampsia, and discuss the care of the woman with chronic hypertension or preeclampsia. Hypertension in pregnancy. Hypertensive disorders occur in 5 to 10% of pregnancies. The most common types are gestational hypertension, preeclampsia, chronic hypertension, and preeclampsia superimposed on chronic hypertension. These contribute to maternal and perinatal morbidity and mortality. Healthcare providers do not use a common definition for hypertension in pregnancy, which makes the classification difficult. The most commonly used classification system is based on reports from the American College of Obstetricians and Gynecologists, or ACOG. This can be found in Table 12-1 in your textbook. This classification system breaks it down into gestational hypertension, which includes gestational hypertension, preeclampsia, and eclampsia, and chronic hypertensive disorders, which includes chronic hypertension and superimposed preeclampsia or eclampsia. The hypertensive disorders in pregnancy. According to ACOG, gestational hypertension is the beginning of hypertension without proteinuria after the 20th week of pregnancy. Hypertension is further defined as a systolic blood pressure greater than 140 millimeters of mercury or a diastolic blood pressure greater than 90 millimeters of mercury. In order to be classified as hypertension, the blood pressure should be recorded at least twice at separate times 4 to 6 hours apart within 1 week. The nurse should ensure that the blood pressure was measured using appropriate technique to obtain the most accurate blood pressure. You may review this procedure in your textbook. Preeclampsia is a pregnancy-specific condition in which hypertension and proteinuria develop after 20 weeks gestation in a woman who previously did not have either. In your book, you will find a table that differentiates mild preeclampsia from severe preeclampsia. I suggest you study this table. Eclampsia is preeclampsia with the onset of seizures. The woman will have no history of seizures prior to the onset of seizure activity. The preeclamptic patient is at high risk for seizures after the birth of the baby, as 1/3 of seizures occur within 48 hours after birth. Chronic hypertensive disorders. Hypertension that is present before pregnancy or develops before 20 weeks gestation. If the mother continues to have hypertension after birth for more than 12 weeks, this would also be classified as chronic hypertension. If the hypertension is mild, the woman will most likely have an uncomplicated pregnancy. Women with chronic hypertension can also develop preeclampsia. This significantly increases the risk to both mother and baby. If the woman who had hypertension prior to 20 weeks gestation develops proteinuria, chronic hypertension with superimposed preeclampsia is the likely diagnosis. Let's talk about preeclampsia. The signs and symptoms of preeclampsia develop only during pregnancy and go away soon after the birth of the baby and the expulsion of the placenta. The strongest risk factors include the woman who is younger than 19, older than 40, a first pregnancy with a new partner, and a history of severe preeclampsia. Preeclampsia progresses from mild to severe. The cause is disruption in placenta perfusion and endothelial cell dysfunction. This decrease in perfusion leads to placental ischemia, which in turn causes the release of a substance that is toxic to endothelial cells. This toxin causes generalized vasospasm, which results in poor tissue perfusion in all organ systems, increased vascular resistance and blood pressure, and increased endothelial cell permeability, leading to intravascular protein and fluid loss and ultimately to less plasma volume. Reduced kidney perfusion causes a decrease in the glomerular filtration rate, which can lead to degenerative glomerular changes and oliguria. The pathologic changes in the endothelial cells of the glomeruli are unique to preeclampsia and cause the loss of protein, primarily albumin, in the urine. Uric acid clearance is decreased, but serum uric acid levels rise. Sodium and water are retained. Renal failure and acute tubular necrosis may occur. Because of the decrease in serum albumin, plasma colloid osmotic pressure decreases, which causes a fluid shift. Intravascular volume is decreased, which leads to hemoconcentration, increased blood viscosity, and tissue edema. The hematocrit increases as fluid leaves the intravascular space. Endothelial damage and increased capillary permeability caused by arteriolar vasospasm can cause pulmonary edema. Liver function levels can be impaired by decreased liver perfusion. This causes elevated liver enzyme levels. If the patient complains of epigastric or right upper quadrant pain, liver involvement should be suspected. Cerebral edema also occurs as the fluid leaves the intravascular space. This results in CNS irritability, which presents as headache, hyperreflexia, positive ankle clonus, and seizures. Decreased blood flow to the retina can lead to visual disturbances such as cotoma and blurred or double vision. In this slide, you will see a diagram of the spiral arteries. The spiral artery you see on the top is a normal spiral artery that has enlarged, and the smooth muscle around the spiral artery has gotten thinner so that the blood flow can enter the placenta. In the bottom, you see a narrowing of the spiral artery. The narrowing of this spiral artery leads to a lot of the problems that you see in preeclampsia. In this slide, you see a diagram of what happens with preeclampsia. You have inadequate vascular remodeling, which leads to decreased placental perfusion and hypoxia, which leads to endothelial cell dysfunction, which this can lead to 3 different issues: vasospasm, increased peripheral resistance, and increased endothelial cell permeability. All of these lead to decreased tissue perfusion. This slide gives you a diagram that shows you what happens with each of the changes in preeclampsia and some of the problems that occur. If you read this slide, if you like looking at diagrams, this slide will help you with learning the pathophysiology of preeclampsia. Now let's talk about HELLP syndrome. HELLP syndrome is a variation of severe preeclampsia that involves hepatic dysfunction characterized by hemolysis, H, elevated liver enzymes, EL, and low platelets, LP. 10 to 20% of women with preeclampsia develop HELLP syndrome. Causes arteriolar vasospasm, endothelial cell dysfunction with fibrin deposits, and adherence of platelets in blood vessels. This causes damage to the red blood cells as they pass through the narrow blood vessels and become hemolyzed, resulting in a decreased red blood cell and platelet count and hyperbilirubinemia. Endothelial damage and fibrin deposits in the liver lead to impaired liver function and cause hemorrhagic necrosis. Symptoms are malaise and flu-like symptoms and epigastric or right upper quadrant pain. Symptoms are worse at night and improve during the day. HELLP can progress rapidly. HELLP occurs more frequently in Caucasian women. With HELLP, there is an increased risk for maternal and fetal death and adverse maternal outcomes, including pulmonary edema, acute renal failure, disseminated intravascular coagulopathy, placental abruption, liver hemorrhage or failure, acute respiratory distress syndrome, sepsis, and stroke. The rate of preterm birth in women with HELLP syndrome is approximately 70%. It can also lead to fetal and maternal death. The management of preeclampsia includes identifying and preventing preeclampsia. It is important to identify the signs and symptoms of preeclampsia early. Physical examination will reveal dependent edema, pitting edema, increased deep tendon reflexes or DTRs, and clonus. Laboratory tests will reveal proteinuria. This slide shows pitting edema. This is probably 3 or 4 plus pitting edema. It's a little difficult to tell on this slide. This slide shows how you would document pitting edema. If it's 2 millimeters deep, it would be 1 plus, 4 millimeters is 2 plus, 6 millimeters is 3 plus, and 8 millimeters is 4 plus pitting edema. This slide shows how to check deep tendon reflexes. Normal is 2 plus. To assess for clonus at the ankle joint, the examiner supports the leg with the knee flexed. With one hand, the examiner sharply dorsiflexes the foot, maintains a position for a moment, and then releases it. Negative clonus response is elicited when no rhythmic oscillations or jerks are felt while the foot is held in dorsiflexion. Abnormal positive clonus is when one or more rhythmic beats are felt when the foot is in dorsiflexion. Proteinuria is determined from a dipstick testing of clean catch urine or a 24-hour urine collection. Proteinuria is when there is a concentration of 30 milligram per deciliter or greater than or equal to 1 plus on a dipstick in two random specimens 6 hours apart, or greater than 300 milligram per deciliter on a 24-hour specimen. Care management of mild gestational hypertension and preeclampsia is usually managed at home with frequent maternal and fetal monitoring. Criteria for home care include blood pressure less than 150/100, proteinuria less than 500 milligrams per deciliter per day, normal platelet count, liver enzymes and creatinine levels, normal fetal status, no signs or symptoms of severe preeclampsia, and a reliable, compliant patient. Initial maternal labs include serum creatinine and platelet count, liver enzymes, and a 24-hour urine. After the initial, all but the 24-hour urine are assessed weekly. The woman should perform a daily kick count to monitor the fetus. Non-stress test or biophysical profile may be done once or twice weekly until birth. Ultrasound is performed at the time of the diagnosis and serially after that. The mother should rest. She will be either on complete or partial bed rest. Boredom can become a problem. Suggest activities that can be done for her from her bed. A regular diet is prescribed with 60 to 70 grams of protein, 1,200 milligrams of calcium, 600 micrograms of folic acid, and 11 to 12 milligrams of zinc, and 1,500 milligrams of sodium. 6 to 8 glasses of fluid, 8 ounces each, is recommended each day. For severe gestational hypertension or preeclampsia, these women have a greater risk for pregnancy complications than are women with mild preeclampsia. These women are hospitalized. Maternal assessments include monitoring blood pressure, urine output, cerebral status, DTRs, epigastric pain, tenderness, labor, or vaginal bleeding. Lab evaluations include platelet count, liver enzymes, and serum creatinine. Fetal assessment includes continuous electronic fetal monitoring and ultrasound. If the pregnancy has reached 34 weeks gestation, birth is usually accomplished either through induction or cesarean section. If the mother is between 24 weeks and 0 to 7 days and 32 weeks and 6 to 7 days, expectant management is considered. Treatment using oral antihypertensives as needed to maintain the blood pressure between 140 and 155 systolic and 90 and 105 diastolic. Ongoing maternal and fetal assessment is conducted. Corticosteroids, betamethasone, is ordered to enhance fetal lung maturation. The dose is 12.5 milligrams IM, and it is repeated in 24 hours. The mother will be on strict bed rest with continuous fetal heart rate and contraction monitoring. The room is kept darkened and quiet to decrease stimulation. Emergency drugs and equipment should be readily available. IV and oral fluids should not exceed 125 milliliters per hour to decrease the risk of pulmonary edema. A central line with pulmonary artery catheter may be inserted to evaluate central venous and pulmonary artery pressures. Magnesium sulfate may be given to prevent seizures, which is a progression to eclampsia. An initial loading dose is given per the provider's order or protocol of 4 to 6 grams and is infused over 15 to 30 minutes. Beware of the side effects that the mother might experience: warmth, flushing, diaphoresis, and burning at the IV site. After the loading dose is given, a maintenance dose is started. The maintenance dose is usually 40 grams and 1,000 milliliters of lactated ringers. 1 gram equal 25 milliliters. It is administered via IV pump at 2 grams per hour. This is done to maintain the therapeutic serum level of 4 to 7 milliequivalents per liter. Remember what the normal serum magnesium level is? 1.7 to 2.2. Now we want it 4 to 7. That is therapeutic. Because of this, you will need to monitor for toxicity. Signs of toxicity include hypotension, bradycardia, bradypnea, and cardiac arrest. Watch for a decrease in the deep tendon reflexes and lower respirations that is normal for the patient. Read more about magnesium sulfate in your book. Antihypertensive medicines are indicated if the systolic BP goes above 160 millimeters of mercury or the diastolic exceeds 110 millimeters of mercury. Hydralazine, labetalol, and nifedipine are effective drugs for treating hypertension in the intrapartum period. In the postpartum period, the woman continues to require monitoring. Continue to monitor vital signs, INO, DTRs, and LOC. Magnesium should be continued for 12 to 24 hours after birth. Continue to monitor for side effects until the medication is discontinued. Most with gestational hypertension will become normotensive within the first week after birth. However, if the hypertension is severe, she may be discharged on an antihypertensive medication such as labetalol or nifedipine. Eclampsia. Signs that eclampsia is about to occur include persistent headache, blurred vision, severe epigastric pain or upper right quadrant plane, and altered mental status. However, seizures can occur without warning. Immediate care involves ensuring a patent airway and maintaining patient safety. Note the time of onset of duration of seizure. Call for help. Do not leave the bedside. Administer oxygen at 10 liters per minute via a non-rebreather. If there is no IV, start one with at least an 18-gauge needle. Magnesium sulfate is the drug of choice for treating eclamptic seizures. If she is already on magnesium sulfate, administer additional magnesium sulfate. Complete a rapid assessment of fetal heart rate, uterine activities, cervical status after the convulsion has ended. The fetal heart rate may demonstrate bradycardia, late decelerations, minimal baseline variability, or any combination of these. These should resolve after the seizure and the mother's hypoxia is corrected. After both mother and baby are stabilized, a decision needs to be made regarding when and how the birth will take place. Prevention is prenatal care for assessment and early intervention of the gestational hypertension. Chronic hypertension. Non-Hispanic black women are more likely to have chronic hypertension in pregnancy. Other risk factors include older maternal age and obesity. Ideally, as with diabetes, management of chronic hypertension begins before conception. Based on the blood pressure and presence of target organ damage, women are classified as high risk or low risk. Women who are high risk are treated with medication and frequent maternal and fetal monitoring for well-being. After birth, the woman should be monitored for pulmonary edema, hypertensive encephalopathy, and renal failure. Chronic hypertension is associated with increased incidence of placental abruption, superimposed preeclampsia, increased perinatal mortality, fetal effects such as growth restriction, and preterm birth. Chronic hypertension. The antihypertensive drugs given in chronic hypertension are found in breast milk. Methodopa or hydralazine are the choices for women needing medication for hypertension and wishing to breastfeed. Short-term studies have not found adverse effects on infants of these mothers who take methodopa or hydralazine. That concludes our lesson on hypertension in pregnancy.